Okay, it's 5 o'clock, so I'm going to get started on time. You'll notice that this session is being recorded. So just to make you all aware, thank you very much, Anu, for organising the event. I'm Caroline Warner. I'm the chair of Ashford and St Peters. I welcome you all very warmly to our annual members meeting for 2024. One or two things before we get started. If everyone could keep their mics on mute when you're not speaking, we'd be very grateful. Then we won't have feedback. If you can't do that yourself, I think one of our admins will be able to mute you. So don't worry about it. And then you'll be able to unmute if you have any questions later. We will take questions only at the end. So we've got a series of presentations, and then people will be able to ask questions at the end. And at the end, of course, in order to let me know that you want to ask a question, just raise your hand. You can also put questions in the chat for those of you who know how to use that facility. Additionally, questions were taken in advance, so Anu has a number of questions ready for us to answer as well. So thank you very much indeed. I will look forward to hearing more from colleagues next, and then from guests at the end. So we're going to get started. And I'll tell you a little bit, first of all, before I pass on to colleagues, about our trust. I hope I have somebody, there we go, organising the slides. Thank you very much. So this is our board. This is what we look like, in case you don't know. It's a particularly unpleasant picture of me, I'm afraid, but that's what we have to deal with. Thank you, everybody, for the service that you give to the board. I would like to welcome some new colleagues who are new since the last annual members meeting. 3 new non-executive colleagues, Jane Dixon, Andy Brooks and Julie Pearce, who've joined very recently. And also in the executive suite of board members, we have Katie Fisher, who's the interim chief executive. This is her first annual members meeting. It's also the first annual members meeting for Jo Fanning, our chief people officer, Jason Binkalar, our chief digital information officer, and Dr. Melanie Irvin-Sellers, who is our interim chief medical officer. So thank you and welcome to all board members, and this is who we are. Okay, so next slide, please. This is a little bit about our trust. I think many of you will be familiar with the kind of work that we do. We serve approximately 410,000 local residents. I'm sure there's a few more than that actually these days, but that's roughly speaking our geography. And we spend it about, well, going on for £500 million of taxpayers' money, providing the services in the local area. We take our responsibilities very seriously. It's a lot of money that we spend on NHS services. That includes enabling us to deal with 115,000 approximately emergency attendances to the emergency department every year, and about 38,000 of those become emergency admissions. 48,000 planned day cases and inpatient appointments and surgeries, and 500,000-ish outpatients appointments and services that we complete, and we did complete in the year 23 to 24, and that's with our wonderful 4,600 staff who help us enable us to do that and to keep our population well and in good health. So thank you very much. The next slide, please. Ashford and St Peters offers a full suite of district general hospital services, roughly speaking, over 3 sites. We have our biggest site at St Peters Hospital in Chertsey, where we have the A&E unit, and intensive care and maternity care and paediatrics and lots of things that you'll be familiar with. And we also have Ashford Hospital, where we do a lot of day surgery as well as planned surgery. That of course we are developing the service there as we build new theatres. That's been going on during this financial year, the build, although most of it hasn't opened yet, some of it has. So next year we'll be able to share more with you about that. And we also operate some services at Woking Community Hospital. I think I'd probably also like to point out that we have some specialist services that we organise. We have the second largest bariatric unit in the country. We also have the regional NICU. For those of you not familiar with that phrase, that means the neonatal intensive care unit. We look after the very, very tiniest babies in the region, and we have very good outcomes. A lot of them do extremely well in our care, and we're very proud of our NICU department. And we also have a national service for gynecology where we get referrals from all over the country. So in addition to our suite of the usual district general hospital services, we have some additional things that we're also very proud of. And so that is, roughly speaking, an overview of our trust. There's an awful lot we do every year, as you can imagine. And we have a wonderful group of people who are delivering care every single day. And another group of people enabling those people to deliver care every day. So thank you very much. I won't dwell on these slides because they're just overviews that people are probably familiar with, but I'm going to pass on to my esteemed colleague, Michael Smith, who is our lead governor. And we are, let me say, I'm very grateful personally, and I think other board members would extend gratitude as well to our governors, but who provide a very important service as volunteers to the Trust, representing their local communities. And I get a huge amount of value. And I'd like particularly to thank Michael, who puts an enormous amount of work in and is incredibly dedicated. And he's a very wise advisor to me as well. So over to Michael. Thank you very much.
Well, thank you very much indeed, Caroline. If we could skip to the next slide, that would be great. Thank you. It just says the foundation, what foundation trusts are. And basically, St. Peter's, Ashford St. Peter's became a foundation trust in 2010. And that's when I first joined as a governor. And I was a governor for 6 years. Then I had a gap. And then I came back in 2019 and still a governor now. Now, we have, as the second part of the slide points out, we're a foundation trust and we have a public membership, and that's you. We have a council of governors, that's us, and a board of directors. And the board of directors run the trust, but the board of directors is also, in a sense, accountable to the governors, because through the non-executive directors, we have contact with all the non-executive directors in the trust. Now, if we could go to the next slide, please. That's our governors. There's 2 slides of this. The beauty parade is also on the Trust's website, so you're very happy to browse that at your leisure. And there are 14 public governors. They come from the areas that the Trust serve. We have 4 staff governors representing 4 distinct areas of staffing of the Trust, and we have 5 appointed governors, 1 each from the 3 boroughs in which the hospital has hospitals. That's Woking, Spelthorne and Runnymede, and 2, 1 from the Royal Holloway College and 1 from Surrey University, who provide educational facilities for us. So if we could go to the next slide, please, that would be great. Thank you very much. The role. Now, the role of the Council of Governors is laid out in the by Monitor as was now NHS Improvements, and that's given us the duties. And the first one, to hold the non-executive directors to account. Well, that sounds really very, very formal and very difficult, because we are very fortunate in our non-executive directors. It's when we say to hold to account, we have the board is composed of 7 executive directors and 7 non-executive directors, and that the board is chaired by a non-executive chairman. So it's an equal balance. But each of our non-executive directors has an area of expertise that, in a sense, shadow the executive directors. We've got John Machin, an accountant. Chris Kane, a man very experienced in strategic change. He worked for a long time with the BBC and moved the BBC up to Manchester, so all our favourite presenters now seem to have Mancunian accents. We have Jane Bell, a vastly experienced nurse, who's very much, and midwife, who's very interested in the performance of the Trust. Simon Devonshire, a fairly newcomer to the board, but someone with a lot of experience in entrepreneurship and in blue sky thinking. And then we've got Don Ero, our digital representative, and all these non-executive, in fact, sort of in a sense, have a close relationship with the executives who mirror what their responsibilities are. Now, additionally, well, I'll just run through this slide first. We, as governors, either live within the catchment area of the hospitals or we are members of staff. So we're all, in a sense, potentially patients or members of staff. We have to agree and approve, and in that sense, we represent the general public. We have to agree and approve certain large transactions, usually big financial transactions. We appoint the Trust's external auditors. We're really lucky in that. We have an external audit system now that is superb. And if anyone's interested, if they just Google ASPH accounts, they can read the latest report and accounts, which is really very interesting. We appoint the non-executive directors, including the chair, and we agree their remuneration, and we have a process of appraisal for them, including the chair. So if we could go on to the next one, please. Then I've talked already about holding the non-executives to account via the governor non-executive director meetings and the council of governor meetings. Now we have a council of governors meeting every 2 months. So we have 6 a year, and they are all attended by the non-executive directors. So that gives us an added opportunity to talk. They follow a very useful cycle that's been set in place by our chair. We appointed during this year we've appointed a new chair, and that was a very, very competitive process, and one that had a very happy outcome for us. We've appointed not one, but we've appointed 3 non-executive directors, and in fact a 4th, who is basically in the wings waiting to take the place when a non-executive director retires, because they are only allowed to serve for 6 years. We've approved the appointment of John to the role of deputy chair, and we've approved the appointment of an interim chief executive, which has been a vastly important thing for the trust. So if we could go on to the next one. The involvement of the Council of Governors. Well, as you read, as well as the usual meetings of the groups and committees, that's the bi-monthly meetings, we've got involved in other different aspects of the trust. We attended the Pride Days, the Pride in Nursing Days, the Staff Achievement Awards, some of the Schwartz rounds, which were a sort of general talk shop, the QI events, the Quality Improvement events, and the Quality Account workshops. We loved to take part in walks around. They had to be suspended during the pandemic, but we're hoping that they will recommence, and we'll, as governors, be able to be taken around the hospitals and have a look at different departments. They've always in the past been really interested. Many of us have attended training events organised by NHS providers. It's very interesting to see what other governors in other trusts experience is. And we are now allowed to have a limited presence at to avoid overcrowding at trust board and subcommittee meetings. And that's also provided a very useful insight. So we have been very involved. We're also involved with the hospital in general, where most of us will, as you will have seen from Caroline's initial slides, most of us will have had experience of the hospital. 1 in 4 of the population served by the hospital will have attended A&E at some time during the year, and 1 in 10 will have become inpatients. So if we could go on to the next slide, please. The governors are elected. There's just 1 position open in Elmbridge, and there's 3 positions going to be open in Surrey Heath, Runnymede, Surrey Heath, Windsor and Maidenhead this year, and an election will take place for those. And sadly, only one of the existing and marvellous Runnymede councillors is in a position to stand again, because governors are only allowed to serve for 3 3-year terms. So we're going to have elections for 4 new governors and for 3 new staff governors. And full details of all the governors are, as it says at the bottom, are available on the Trust's website. So if we could carry on to the next one, please. So their reflections on the year. Well, it's been a very, very interesting year indeed. It's been a very difficult year. We had the recovery from COVID process, the COVID pandemic, and it's been very challenging. We had in the early part of this year the loss of a chief executive. She had only had a comparatively very brief term in office. And before that, our chief executive, Suzanne, had been borrowed from us by NHS England for some major COVID projects, the test and trace and the Nightingale hospitals. So we had a bit of a gap in leadership at the at the top of the trust, but very, very happily, we were able to bring on board Katie Fisher, who has actually been, in the time she's been with us, made an immense difference. She's brought things to life again. She's got a lot of enthusiasm, a huge amount of enthusiasm, and sadly, she won't be with us for all that many more months, but in the time she's been with us, she has made a very, very real difference. But one thing is the other thing that's compounded our difficulties. We've lost a medical director, we've lost our chief nurse, and those posts have now been filled, which is a huge relief. The new chief medical officer will be taking post in December, and the new chief nurse in January. But what I ask myself is, what is the most worrying feature for the trust? What are we facing in the future? Well, I think that I had a chat with Katie about this the other day. And we agreed that the real worry that we have is the coping with the pressures that will happen in the winter. Already in July and August, we found the hospital under immense pressures, both through A&E and with the backlog of elective procedures that were delayed through the pandemic. So that is the big challenge. So if we're overwhelmed in July, or let's say having to resort to care in the corridors at some times, and some escalation wards that are not really suitable for inpatient stay, but more designed for day cases, that's worrying in July. But come January, it's a very, very concerning thing. And there's not a lot that we have been able to foresee that will relieve the pressures, because the pressures put on A&E are relentless. The number of people attending goes up year by year. The number of people who are seeking advice on NHS 111 has gone up to 1.5 or more million each month. That's an increase of 50% over the last 5 years. And many of those people are advised to go to A&E at times when their local practice is not open. So the demand is relentless. We are coping as very much as best we can, and we do hope very much that we will weather the storm. The opportunities that we have are quite limited, but speeding up the processes, speeding up discharge, and freeing up space will be a top priority. So that's the challenge for next year, or this coming year, and very much on people's minds about what will happen. So that's my reflection on the year. It's been a challenging year, it's been an important year, but it has been a year of solid progress, and not least in the recruitment of our non-executives. I'm coming just back to that, because I did mention our long-standing non-executives, but what's particularly exciting is that we have decided, both as a board and as the governors, that we wanted a more clinical focus. And we've managed to recruit 2 clinical non-executive directors. Andy Brooks, with a vast experience in general practice, and Jane Dixon, a hugely experienced health professional in hospital practice, and they'll be joining the board, or have joined the board actually, from last month. So that is very, very good news. And in the wings, as I say, we've got an associate non-executive, Julie, who will be, let's say, taking a post as soon as a post becomes available. So we're very happy to have a full complement of non-executives and now a full complement of the executive board. So thank you. With those thoughts, I hand you back to Caroline and say thank you very much for your welcome, Caroline, and happy to work with you.
Thank you, Michael. It's always a pleasure. Okay, thanks very much indeed. And I'm passing over to Katie now to give you a sense of the strategic objectives of the organisation.
Thank you very much, Caroline. I sort of want to I've got some slides here, but my main job is to introduce executive colleagues who are going to talk through some of the achievements in the last financial year against the 5 areas of our strategic objectives. Could you have the next slide, please? I think it's really important to say within our trust strategy that it was initially launched in May 2018. It was refreshed in 2023. It is very much watch this space, because we are imminently in that we are taking to our board meeting on Thursday our first clinical strategy, which is a much more granular plan driven at an individual service level to really show what our ambition is for our services and how we best serve our communities over the next 3 to 5 years. So this is a broad strategic framework, but actually we are currently very much engaged in refreshing very detailed specific plans. But the current overarching strategy is made up of 5 strategic objective areas. And in a minute, I'm going to hand over to different directors who are going to go through some, as I said, some examples of key achievements over the last year in each of those areas. Our trust strategy was obviously developed as part of a local and national context. We are part of a broader system. We're much stronger through the collaborations that we gender, the strength and maturity of the relationships we have with partners across health and more broadly care, to make sure that we are delivering the sort of holistic approach to end-to-end care for the citizens that we have a duty of care for. I think it's really important that you'll hear through the episode that that's a really key feature of all of the activities we're undertaking, that actually we absolutely cannot stand in isolation and think about what happens when a patient walks through our door or when they leave at the other end of their pathway, but really making sure the total needs of our communities are met and what our important role within that is, not just as a care provider, but also as an anchor institution, a large local employer, and a contributor to the local economy. Next slide, please. So I'm going to hand over to Ellen in a second, but really to leave you with our vision, which remains unwavering, is really to provide an outstanding experience and best outcome for patients and the team, underpinned by our core values. And that you'll see really running through throughout all the presentations that we have. So I'm going to hand over to, I think Mel is with us. This was very last minute. So Dr. Melanie Irvin-Sellers has been really poorly, and I was sort of hoping that perhaps, she might stay resting, but I think she was determined to come and share this occasion with us. So I'm going to hand over to Mel and to Ellen, our chief nurse, who's going to talk us through the quality of care section.
Thank you. So good evening, everybody. So I'm Ellen Bull, I'm the interim chief nurse. I'm going to start and then I shall hand over to Mel. So yeah, delighted to say that since our CQC inspection, we've got a completely transformed maternity service, both in terms of the environment, where we've had a complete upgrade and reconfiguration of our triage service and our Joan Booker ward of the anti and postnatal ward. The workforce is completely transformed in its shape and size. We've got leadership development with a director of midwifery substantively appointed and a head of midwifery substantively appointed, and a much larger governance team, which will work very closely with our own internal team in the corporate team. We've had a huge improvement in our vacancy rate over our clinical midwives, and that's something that is really noted at regional level. So we started last year, in the early part of last year, with a over 30% vacancy rate, and we're well down now to under 10%, and we are aiming to have an under 5% vacancy rate. We're doing really well on that, and our student midwives, we are recruiting most of our student midwives. 15 of those started this week. So we are really on a journey to almost full substantive filled vacancies, particularly around our clinical workforce in midwifery. We still take our student midwives from 3 universities, and we've got many onward pathways to support ensuring that we have opportunities to become a midwife, both pre and post registration. So that's been a real journey, and we're very proud of what's been achieved there, and a real improvement in our staff and patient experience as well. In terms of the student midwives, again, their experience is reported very favourably, both internally when we go around and ask them, but also at the university level, and they're well supported by a clinical practice education team who support them through their pre-registration experience and in their first year of being a qualified midwife. And I think I'll just stop there and hand over to Mel, actually, Dr. Evans-Sellers, just to talk a little bit about tobacco dependency.
Thank you, Ellen, and thank you, and good evening, everybody. We've always offered smoking cessation advice throughout the hospital and to our patients in Ashford and St Peters, but we've actually formalised this within the last year, and in December 2023 created a more formal way of doing this to ensure that we capture everyone who needs it as an inpatient, and also patients coming through our maternity services as well. Staff are able to make a very quick and easy referral to the cessation team through our electronic patient records, and they will assist smokers and advise on how best to stop smoking and offer the best form of nicotine replacement therapy for them. Patients are seen face-to-face by the tobacco dependency team when they're inpatients, and then when they're discharged with a supply of nicotine replacement therapy for a couple of weeks and referred onwards to the community-based service, which we call One Use Surrey. The other thing that we'd like to talk to you about this evening is our surgical site infection project work, and we've continued to work hard to reduce our surgical site infections through our surveillance programme, which has shown ongoing improvement. We've got an in-hospital database which has been in operation since July last year, which is capturing data for the 9 procedures across all surgical specialties. We have experienced a few challenges with staffing and accuracy of reporting. However, we've got new individuals taking up vacant posts within some senior leadership areas in the infection prevention and control team, and we'll be reviewing our methods and processes to ensure that we're fully in line with national guidance, and we continue to sustain our improvements and continue to get better. Ellen will just take you through the Healing Arts programme.
No, thank you, Mel. Yes, so something which is complementary to all of our care is our Healing Arts programme, which has been in place since 2019. And different forms of art helps to improve staff and patient environments, leading to more positive experiences and improved outcomes, and there's illustrations of this actually throughout the trust. It works across all of the departments, and we've got beautiful pieces of art and architecture, and lots of community engagement. Actually, 2 things of note are the 2 gardens which we have installed just actually down on the ground floor to the right of the main entrance by our Willow Ward area, actually. So we've got our staff garden called the Queen Elizabeth II Staff COVID Recovery Garden, which is a beautiful space with a wonderful memorial in it to remember our staff that we lost through the COVID pandemic. And that was officially opened by the Duchess of Gloucester, which is a really wonderful occasion. And if you haven't seen that, I'd recommend having a look at that, because it really is a beautiful space and reminds us of how we all came together to look after our patients and our staff during that period of time. The Serenity Garden, that's also been lifted and shifted from the Hampton Court Garden Festival, designed and donated, and has been put into that space in that Serenity Garden, and that's also a really beautiful space as well, and is what it says, beautiful and serene, and again a place of reflection. And something which is quite live at the moment is working with the Chertsey Museum on the St. Peter's History Project, where they're attaining staff and wider stories about the history of St. Peter's through the years. And I can attest to that, having been given my account of the COVID pandemic, and many other staff have been involved from many years. So we're really looking forward to seeing that develop. So I'm now going to hand over to Pammy, our Deputy Chief People Officer. Thank you.
Thank you, Ellen. Good evening, everyone. Thank you for the introduction, Ellen. So I'm just going to take you through a few examples of what we've done in the previous year, and inevitably, and I think it's a cliche, but it's a really true one, that people are our biggest assets, and we need to look after them and focus our energies on developing and supporting them. So we've been focusing on a number of key priorities aligned to our people strategy and the NHS people promise themes for how we support and look after our people, develop the right culture, and ensure that we have a workforce that meets the needs of our patients and local population for now and in the future, and also the need for us to ensure that we have greater collaboration working across our system, something I think that we've touched on by our previous speakers. So just really focusing on a number of key areas. The Trust has been a part of an exemplar programme run by NHS England to improve outcomes and optimise staff satisfaction and retention. In that programme, we've been focusing on supporting staff with work-life balance and flexible working culture, and also focusing on our well-being, which actually focuses across 6-pronged approach, which is cultural, emotional, environmental, financial, physical and social, being very cognizant of our financial circumstances, environment, both locally and nationally. We ensure that staff have access to a range of support, and that includes employee assistance programme, which is accessible fairly quickly and fairly robust. We also have on-site pastoral wellbeing support and also psychological incident debriefs services. So actually, if an incident takes place, we can very quickly mobilise support to our staff and ensure that they're supported. Our workforce is front and centre in driving inclusion. We're very focused on that. Want to make sure that environment is and our culture is very inclusive. As part of that initiative, in 2023, we launched our career development mentoring programme, which is a multi-stakeholder collaboration designed and delivered through our learning and development team, our clinical education and our equality and diversity teams. We've scaled this up this year. It's been very, very successful. We've already had a number of people who have been promoted as a result of that. And it's very much supported by our executive colleagues and our non-executive colleagues through the mentoring process. So each individual who enters that program actually gets support through a mentor, and it's very, very well thought of, and we get very, very positive responses through that program. So very, very proud of that program. In terms of growing for the future, we're very much focused. We've been focused on recruiting internationally. However, we are now looking at how we support our local and national recruitment through offering placements, work experience and insight days. Insight days typically through our schools, so very much linking as an anchor institution, working with Northwest Surrey schools and colleges for pathways into the Trust via our apprenticeship programme. And we're also part of the Surrey Heartlands and South East Collaborative Banks, really looking at our temporary staffing practices and processes to reduce the reliance on on agency staff, and looking at bank rates essentially. We're also looking at how we provide continuous professional development in terms of new ways of working and delivering care, and looking at opportunities for all our staff via the apprenticeship levy and the workforce development funding programs. We're also developing an online offer, specifically looking at training to ensure easy access to all our staff. Appraisal is a really, really important of our process in terms of our development, and we're looking at our digital workforce systems to eventually to offer an e-rostering to all our staff. I think that's kind of all I'm going to say on this. Thank you for listening, and I'm going to pass over to James Thomas, our Chief Operating Officer.
Good afternoon, everybody. Can you hear me okay? Yeah, perfect. Hi, my name's James. I'm the Chief Operating Officer here at Ashton St Peters Hospitals. I'm going to talk to you just a little bit about some of the exciting achievements we made during the last financial year in terms of services that we delivered to our patients. So at the top left-hand corner is our relatively new urgent care building. That's where we have our combined assessment unit and our same-day emergency care. And we've had some really exciting developments in the past 12 months. We've introduced a new form of seeing and treating patients called ratting, so that we can make identification of what people need earlier on in the pathway. And there's a whole lot of other improvements that happened through last year into this year that's led us at the moment to have some of the best times for some of our patients for up to 3 in the last 3 years. Another big project that our teams undertook this year was ambulatory majors work. There was a movement around of some of the internal services that we had in ED and where we positioned them and what buildings they were in. And that enabled us to put a nurse in charge and a doctor in charge of that specific area. And the teams really have made a big difference to patients who are able to walk and be mobile. That really has been an improvement that we should be proud of. Looking across, so to the bottom right-hand corner, we've got a picture of the bariatric team. And last year was a really exciting year for them. So as we came out of COVID into last year, and as Michael described in his opening thoughts around the governors, it was a very difficult year as we come out of COVID for our waiting times. This team had waiting times for first consultation of just over 2 years at one point. So they introduced monthly weekend clinics that were the big hitting clinics, big throughput. We're getting through 80-90 patients a weekend in those clinics, and it reduced their waiting times down to 6 months. So that really was an impressive achievement for their patients. The other thing that they introduced was their surgical hit list that they called. So once they got the waiting time for outpatients down, they moved across to looking at their waiting times for surgery. And one of the really exciting achievements they had, they spent a lot of time visiting hospitals in Europe and really working on how could they make their pathways more efficient. And they managed to treat 9 patients in under 4 hours, or 4 hours, 40 minutes. They used 2 theatres. They learned all of the techniques and the ways of processing patients through theatre from the hospitals they'd visited. We got 9 patients through in the morning. It's normally 3 on an all-day list. So that really was an impressive achievement. And one of the next achievement is on the bottom left. This is how we look after patients with chronic liver disease. And this is just an example of a lot of innovative thinking, innovative changes to clinical pathways to look after our patients better and more swiftly. And what the team have done here is for the patients who have chronic liver disease, we've introduced a service that means that these patients will be proactively monitored and drains and things done on a proactive basis. Now, in the summer last year, we got 20 patients through this new service and 13 in August. All of those patients would have had at least a 3-day admission. So treating patients outside in a clinic or a day case setting is really important to improving the quality of their experience and keeping people at home when they can be. So a range of really exciting developments here. And the last one, I'm not going to steal my own thunder because I've got a double billing on tonight's meeting, and towards the end of the meeting, I've got a few slides on the elective centre, which really is exciting. So I'll save that one for that section. So that's it from me, and now I'm going to hand over to Jason Binkler, our Chief Digital Information Officer.
Thank you, James. So, folks, I'm going to point out the obvious here. If we didn't live in the digital era, we wouldn't be able to meet like we're meeting today, right now, obviously in this virtual world. And I think what that demonstrates, though, is how we've had to modernize and change our approaches and effectively accept digital now, not as something additional, but actually as a regular way of actually working and living. And it's the same for digital in healthcare. So what we're now seeing is that we understand a lot more about our patients and we build up a rich history around our patients because what we can do to use digital. So now we have electronic patient records, we store that history, and we can actually share that history. What you're seeing on the screen actually is a roadmap that really says that digital in our organization has a purpose. It isn't just a utility that we leverage sometimes, it is actually part of the patient flow now that we leverage almost all the time. And of course, as part of our strategy, hopefully we'll be seeing not just our own staff leverage digital, but also the patients as well. Now, what we know is this: by the comprehensive use and the contemporaneous use of digital solutions, we will effectively improve safety. We'll know far more about the patients, we'll know about reactions, we'll know about history, we'll know about how patients want to be treated. We also then know how we can tailor our services around the population health and improvements around using medicine and science together to obviously ensure that we're providing the right intervention at the right time and in the right place. So of course, what this means is we're going to create a much better environment for both patients and our staff. And then of course, what we want to do is enable us to take the intelligence that we've built up around our patients and share that further with the healthcare system. And that might be across our integrated care system with other provider organizations, but also actually with other parts of the United Kingdom, where effectively we allow our patients and citizens to become far more geographically mobile. So of course, the technology means that the patient history and the patient record can travel in near real time, enabling patients to get back to obviously where they're from. And our neonatal intensive care service is brilliant. They effectively retrieve patients from around the country and they share an electronic patient record, enabling all of that care to continue with all the history as well. So the seamless transfer of data is really important. We share this across Surrey in the shared Surrey Care record, and also we have other ways of sharing this nationally with the NHS summary care record as well. Data that we build up around our patients and the way we provide our services enable us to actually gather insights and effectively increase our productivity while improving the patient experience and the staff experience. But what's really important now is we use a lot of the routine data that we collect. So right now we've built effectively an ecosystem up around patient records, staff information, corporate data. But what we want to do now is actually pivot from just collecting this data to analysing the data and effectively move up along an epistemological journey from obviously taking that data, turning it into information, then turning that into knowledge, and then of course wisdom. Of course, using this data and information, knowledge and wisdom to actually provide better services that obviously mean more for the patients and enable our staff actually to know they've done a great job as well. So we want to use more and more of this data. Of course, if we do, we can then obviously plan services to be more effective, but actually predict demand. So where our strategy takes us from is from being a service that effectively reacts to the next referral to be an organization actually that's able to predict demand and effectively stand up the right resources at the right time in the right place to give that best possible service, but also to help us create an environment where will be long-term sustainable. And then lastly, actually, I've spoken about the data that we collect in electronic patient records that we use within the organization and within the healthcare system. But effectively, we are stewards of the data. And the data is really patient data and citizen data. And we want to actually put that data in the hands of patients and empower the patient. So we're doing that through what we call patient engagement portals, so PEPs. And that's a national term that we use. But very simply, earlier on this year in February, we released the MyCare patient portal. You'll see a lovely little picture there on the screen, effectively of a mobile phone device there, showing you effectively that you can enter into, register with the portal, and then access elements of your care record. So right now you see some elements of what we hold around a patient. You'll see things like appointments, and you're starting to see more correspondence. But it is my vision and my goal to ensure that everything we hold digitally about the patient is actually presented back to the patient through the portal, and we enable patients to transact for themselves, such as rescheduling an appointment, initiating a follow-up, recording and reporting outcomes, engaging in secure messaging with clinicians, and also able to submit preoperative assessments, electronic consent, friends and family tests, provide other feedback, and then, of course, where necessary, share that patient record with other care providers, other organisations, as the patient wishes to do so. So all this, of course, wouldn't be possible without digital. But of course, digital doesn't serve a purpose on its own. It is around having that really good symbiotic relationship between the clinician, the administrative staff, the patient, all working together, of course, using data and technology at the right place. Two other things for us to consider, though. The world is changing, and we hear about artificial intelligence. So, of course, using technology can learn patterns and trends, can start to make predictions, can start to provide our clinicians with decision support, can help prioritize workload as well. So we're looking to embrace that in a couple of different areas. We're looking to reduce missed appointments using these predictive algorithms. We're also looking to actually have technology provide a way of following up with patients after a form of intervention to gauge how the patient feels, to help inform our clinical staff around what the next sets of engagement should be, depending on how the patient feels as well. So a couple of opportunities for AI there. There's been many opportunities over the past 5 years in diagnostic imaging, where effectively AI has seen where it believes there's a problem, helping to signpost clinicians to seeing those types of things. So that's one thing for us to consider, is in our roadmap. But then the other thing for us to consider is that line that you see across the top, cybersecurity and data protection. So while we make things more accessible digitally, and while my team and my other practitioners across the NHS work really hard to promote the use of digital and technology to do better things, unfortunately, though, we have to understand that by making it more accessible, it could be misused. It could unfortunately lose its confidentiality and its integrity. So we are looking for better ways to protect this. Part of this is through using more and more technology, layers of defense, as we call it. But the biggest defense that we do have is education. So educating, of course, patients how to keep their information confidential, educating their staff as well to be more confidential. So those are things for all of us to consider. And then my final note is this. With all of the data that we've got and all the technology innovation, actually, we are in a brilliant place, actually, to encourage the more use of this, to enable more clinical research, and produce better interventions in the future. So it is through data, I believe, that we can influence medicine. Okay, that's all I've got for you for today. So thank you very much. I'm going to hand you on to my colleague and friend, Tom. Thank you.
Thank you, Jason, and good evening, everybody. It's good to be with you all again at this annual members meeting. I would like to talk to you about Collaborate, which is our fifth and final, last but by no means least, strategic objective. And clearly collaboration underpins everything that we do. It is an essential part of the way in which we do business here at ASPH. There are a number of really key collaborations that we're part of, and just on the back of Jason then introducing to us the opportunities from AI, I thought it was important to mention the collaborations that are helping us with that. So we're part of two huge clinical networks, one in pathology and one in imaging, both of which enable us to access the best practice and the best technology out there to support those pathways. Really important. I have probably already talked to you about our collaboration within Northwest Surrey, the Northwest Surrey Alliance, which you can see there on the slide. So this is probably one of the biggest public sector alliances in the UK, and we've been part of this now for a number of years as a formal alliance, and for several years before that working towards it. We're one of 11 partner organisations bringing together local health and care organisations. So as well as us, the acute part of the system, we have primary care, the GPs, the GP Federation, community care in the form of CSH Surrey, our mental health provider, Surrey and Borders, adult social care, our local hospice working in Sambir are part of our alliance, and really importantly, our 4 borough councils, Runnymede, Woking, Spelthorne and Elmbridge, who do so much out there in the community to support people to be well and to live healthy and fulfilling lives out there. The partnership is really all about joining of health and well-being and social care needs, so that we can make sure that people are in the right place for the care that they need when they need it, and that we can keep people well together at home wherever possible. And this partnership here in place in Northwest Surrey is really critical to enabling us to continue to provide effective and sustainable services as high quality as they can be, and to tackle the challenges that Michael and others have mentioned around the pressures on ED and the challenges that we face in the winter and now increasingly throughout the rest of the year as well. As well as working in partnership and collaboration here in our local place system, we work very effectively across Surrey Heartlands, which is our integrated care system, and we are one of 4 acute providers, us, the Royal Surrey Hospital Trust, Surrey and Sussex Hospitals, and Surrey and Borders Partnership. And together, the 4 acute partners have formed a formal trust provider collaborative that enables us to combine our strengths together to improve health and care outcomes, tackle inequalities across Surrey Heartlands, and to boost productivity and ensure that we are able to contribute towards broader social and economic developments for our population and our area. As well as that, we are working in collaboration with a number of key partners. So Macmillan Cancer Charity, that you can see there, have very kindly invested, or in the process of investing, around £2 million in the creation of a cancer information centre and support centre, which will be located at Ashford Hospital, and which we will be starting to build next year. That centre will be offering free advice and support to people suffering with cancer within our area, but also to their families and to their carers. It will provide a hub for people to access information and support. There'll be practical advice, support around the emotional coping to do with cancer when people are on cancer pathways, access to specialist nurses and clinical advice, and the opportunity to take counselling sessions, complementary therapies, and exercise classes and support groups. We already have 2 Macmillan information and support advisors working with us on those services, ahead of us putting together that new information centre with the support of Macmillan Cancer. I also want to mention the Woking Diagnostic Centre, which is a major development that we have carried out in partnership with Surrey Heartland's Integrated Care system, but also with our partners and colleagues at Woking Community Hospital, CSH Surrey and NHS Property Services. We are partly open in that centre now, so we opened our cardiac and respiratory testing services there in May, and we were very grateful to the Rotary Clubs of Woking to support us in the development of those services. And we have also opened our ultrasound and blood testing services there. We take delivery this weekend, I believe, of the modular building components that will enable us then to open up our MRI, CT and our mobile breast screening facilities there before Christmas. So really important development there for Woking Community Hospital, and again working in partnership with our local primary care and community care partners, we'll be able to improve access to diagnostics for the population of our wider area, so that people are able to get the care that they need when they need it, or to receive the reassuring advice of a clear diagnostic when they need that. I'd also like to mention our community days, and you can see some photographs from them. So we held 2 community days over the last year or so, one at St Peter's back last summer in July, and one at Ashford Hospital. And many of you will have attended our community days. I'm sure they're a great opportunity to come and see the hospitals when they're not jam-packed full, and when we can open up the doors for the community to come in, talk to our clinicians, and get a feel for what it's like to be in the hospitals, and maybe to work within our hospitals if people are considering those kinds of careers. And we'd love to share information with our community and with our population, and to enable people to network together. And we often see our local charity and voluntary sector community organisations coming along and joining us in those days. And then finally, and on the right-hand side of your slide here, I'd just like to mention the ASPH charity. I know that I had a major slot at the last annual members meeting to talk about our charity, but I like to take every opportunity to highlight it. Our ASPH charity raises funds to enhance the hospital environment, to improve the patient experience, and to improve the care environment, the working environment for our staff. We're really focused on raising our profile, and we're really focused on continuing to do whatever we can to raise funds to support the trust. We enjoy the support of lots of our local community, local corporates such as Samsung Electronics, who volunteered our help to help tidy the gardens at the trust. Ellen's already mentioned the Serenity Garden donation that we received from RHS Hampton Court, and RHS Wisley have also donated a garden to us at the Bradley unit at Woking Community Hospital. And as well as that, the charity funds our ASPH in Bloom garden development project that's been running now for a couple of years, and we've developed something like 20 gardens that our staff have put together across our hospital sites at Ashford, St Peter's and at Woking. And then I'd like to mention just a couple of other things. So around 100 of our staff have taken part in charity events, running events, challenge events over the last year, raising something like £50,000 for the ASPH charity. So a massive shout out and thank you to them for all that they've done, and thanks to all of those that have supported them with donations. And as ever, our ASPH charity website has on it very straightforward linked through to sponsor people who are raising funds in that way, or for any other good cause that you can see on there. And then that brings me finally just to mention aquablation, which is an innovative new treatment that we have now brought online for benign prostate enlargement. So gentlemen of a certain age, I'm sure your ears will prick up. We are one of the very few trusts in the country now offering this service. And we're in the process of raising around £130,000 to enable us to do that. So please do donate to that. And I will now, with that, hand over to Simon.
Thank you, Tom. And Hello from me. My name's Simon Marshall. I'm the Chief Financial Officer here at the Trust, and it's my pleasure to present the annual accounts to everyone here today. If we can just flip forward a slide, please. So, look, we've seen some great things today, haven't we? But the finances across the NHS remain a challenge. We're not unique in that, and increasingly finances are managed at a system level. So in theory, one organisation in deficit can offset that against another organisation in surplus. And there was a bit of that going on last year with our partners across Surrey Heartlands. We planned for a £17.5 million deficit last year. That was delivered, and because of that, some of the surplus that was generated by Surrey Heartlands was transferred to us. That was £8 million, and that reduced the year-end deficit to £9.5 million. Now, there is some accounting adjustments going on with that, but £9.5 million is the deficit that we get monitored against, and that was formally reported. So that was good news in terms of delivery of our plans, but we still have the challenge to resolve that, really. I should say, probably as part of that, and you'll see it on the next two slides, the income across the NHS is increasingly being curtailed or reduced, and our expenditure is still under considerable pressure. And that's fundamentally why, when you look at the chart at the top there, our finances have been deteriorating. So I'll say a bit more about that on the next slide, if I may. Perfect. So I think it was said at the beginning of the session, we earned last year 444 million. That's an enormous number that's seen substantial growth, certainly over the last 5 years or so. The bulk of that comes from our NHS services. We're paid that by our commissioners, so in the main Surrey Heartlands, but also neighbouring commissioning organisations and NHS England. We also receive a substantial amount of education and training income, and then various sources of other income across the trust that we manage to generate as well. That 444 million was still up 3.5 million. 3.5% last year, £15 million, sorry. So pretty substantial growth in historical terms, but we've done a lot more work, again, has been demonstrated throughout the presentations, really. So if we go on to the next slide, you'll see where we spent that. Most organisations will see something like 64% go on the various types of staffing. So that's across our medical staff, our nursing teams, and our clinical and our non-clinical and administration support and teams. We spend substantial amounts on buying in supplies, drugs, and other devices that we use all the time, really. We do outsource a relatively small amount of services. That's been decreasing in recent years. So we spent about 3% last year on buying in clinical services from other organisations. That might be in support of the Urgent Treatment Centre, for example, or some of our MRI scans are done by private organisations. And everyone's always interested in how much we pay on clinical negligence. That's an insurance premium if there is harm done to patients. All of the NHS has seen significant cost pressures there. For us, that was up 13% last year and 16.3 million in total. I should say that's just the premium. The value of potential claims against us is that's managed through the NHS as a whole is substantially higher than that. So fundamentally, our challenge, though, was that our income is rising by that 3.5% I mentioned earlier, but the costs were going up by 5% last year. So clearly, more to be done around productivity, efficiency, throughput, and cost controls, I guess. On the final slide, it just looks at our capital expenditure, and there's a number of schemes that we've undertaken in recent years. Obviously, that digital investment, for example, last year that Jason was alluding to, we do a number of rolling refurbishments across the trust on an ongoing basis. We spent a lot of money last year on Abbey Wing in particular. Clearly, we've also, and James will say a bit more next when I hand over around the elective centre, but the investments in Ashford and at Woking Community Diagnostic Centre have been substantial as well. Not through us, but with partner organisations, we continue to improve our staff accommodation, particularly at St Peter's. We're now well through those phases. I think phase 2 is opening later on this year. So you'll see that at the top and the back of the site, and phase 3 is the redevelopment of the existing buildings, which will continue next year. On top of that, we've invested heavily in our equipment, in our kind of backlog maintenance on the site, so particularly our electrical systems last year. And we continue to invest around, health and safety and fire standards and various rolling equipment, cyber resilience, all that kind of stuff as well. So a huge amount has gone on across our finances. There's more to be done, clearly, but we're tackling that head on really across the trust, and there'll be more on that next year. James, I think I'm heading over to you to give a bit more information about the elective centre.
Thanks very much, Simon. Thanks, everybody. So yeah, I'm just going to take 10 minutes or so to talk you through what's happening at Ashford in terms of our elective centre, which is one of our most exciting, I believe, one of our most exciting developments in the organisation. So I'm going to talk to you a little bit about these 5 things. So what are we doing and why? What are we building? How's that going? We're happy to take people to run this centre. What does that look like? What are we doing in the meantime to get things running as a productive centre? And a few things about how we're looking to run the centre and attract patients to it. So this is a slide about why do we want an elective centre at Ashford. The key reason is because what we wanted to do, and it's in the top right, was split elective work from emergency work. And the reason for doing that is we can provide a side of Ashford that's uninterrupted, that doesn't get affected by ambulances coming on site and the pressures that we have on the acute site. So it becomes quite an attractive proposition that cancellation operations aren't cancelled on the day for reasons that we hadn't predicted. And it becomes very productive. There's a whole scheme of work nationally around elective centres, and we are very fortunate to get awarded external money in the tune of around 10 million to support the cost of investing in our centre. We're going for GIRFT accreditation. So GIRFT is the Getting It Right First Time programme. They're looking at supporting elective hubs such as ours in hitting levels of productivity and throughput that at the moment isn't normal in many hospitals. There are opportunities for us through critical mass. The exciting part about this, as I talk through my slides, that will begin to come together, that as we get more patients having their orthopaedic operations, particularly at Ashford, that increases the level of, or the volume, the activity, the critical mass. And that becomes exciting for a number of reasons. It gives us the opportunity to innovate, to try new things, to develop exciting roles. It gives us an opportunity to train and educate the next generation of surgeons, orthopaedic surgeons through the unit. And it gives an opportunity for research as well. So that critical mass is really important and really exciting. And we've got on here, there's activity that we have long waits across Surrey Highlands, but there's also activity that goes up to the private sector that to support the agenda Simon's just been discussing around financial challenge. If that money was coming into the NHS, that would help things as well. Thank you. So what is the elective hub? Well, we're building 4 new theatres that are opening in January. So that gives us a total of 12 theatres in total on our Ashford site. And under that, you can see that we're Currently, we have 29 orthopaedic beds. We will have 10 dedicated day surgery orthopaedic recovery beds, and we'll also have 12 inpatient surgical beds as part of this. So that gives us in the region of just over 5,000 additional elective operations that we'll be undertaking through the centre. Now, there's an awful lot of building work. Those of you who have been to Ashford recently, certainly if you go past Tesco's and look back at the building, you'll see that all of that end of Ashford building is scaffolding. And if you look at the quadrangles there inside the building, the gardens as you look in, both of those are filled with scaffolding as well, all supporting the work that's going on here. So if I just describe one move to you, and this is one that's happening at the moment, ophthalmology is currently going to its new location, which is the whole top floor of the Ashford building. And in that top floor, they have dedicated outpatients, they have laser rooms, treatment rooms, they have theatres, outpatient space, recovery beds, all of those things on the top floor. So moving out the services that were in there, building all this work and moving ophthalmology in is classed as one move. We're doing 19 of those moves in order to make all of this happen. So an incredible amount of work. And some of that's already happening. So our outpatients for paediatrics and pre-op assessment opened in August. Those services have moved downstairs so that the building work can happen upstairs for ophthalmology. So those eye theatres will be online in January, as will theatres 7 and 8. So a very exciting set of moves, a lot of work happening, and not long now until we take delivery of those theatres and start using them to treat more patients. So as well as building and doing an awful lot of work over at Ashford site, teams have also been working on people. We need more people to undertake the work at the elective centre. So about 149 people we're taking on in total. And this is everyone from consultant orthopaedic surgeons, sporting teams, anaesthetists, ward nurses, imaging, therapy, and booking staff. So in total, it's a very complicated set of processes that we need to support when it comes to treating people. So it's around 150 people. We've currently taken on 75, and we're working towards recruitment of other people that have a shorter leaving time that's going on at the moment. So that's really successful and working very, very well. So the third thing that's happening is it's good to have new buildings and more space. It's great to recruit more people, but what we really need is a thriving, exciting, productive and efficient environment at Ashford. And that's what you can see that we're beginning to create here. So in the top left, to start there, theatre utilisation at Ashford, certainly for orthopaedics, is continually above 80%. We've had a bit of challenge in the summer and we're returning again, but it's at over 80%, and the benchmark is 85. We want to get above that, but it's a good place to start from. And it's not just about how well we use the list, how long our sessions last, but how many cases we can get through per list. And that's gone from 2.2 to 2.6. So you can see that we're undertaking more cases on each list that we do at Ashford. We're supporting already, before the theatres have opened, we've been supporting Royal Surrey and Sash hospitals. We've undertaken 60 cases on behalf of them at the moment. We've moved to one joint for hips and knees, which were one of the few orthopaedic trusts that have been able to do that. And at the same time, we've adopted robotic positioning for hip and knee replacement, or for knee replacement. So we've done 100 of those. Actually, it's a bit more now. And in terms of our length of stay, that's been a huge amount of work from the orthopaedic team and the anaesthetic team working together. So our length of stay now has gone from 4.5 days to, well, it's actually less now. It's actually less than 2.5. It's about 2.1, which is an incredible step forward. So literally halving the length of stay in 12 months. We've had 7 patients go home within 24 hours of their operation. We've had 100 go home within 35 hours of their operation. So what we're doing at Ashford is not just about recruitment and buildings. It's about efficient processes for our patients and making things easy for our staff, that they can work in an environment that's easy to work in, productive and exciting. And then this is a bit that we're working on at the moment. So phase 1 is as I've described. It's those things. It's about undertaking an additional 120 orthopaedic operating sessions per month on behalf of our patients in Ashford and St Peters, patients at the Royal Surrey, and patients at Surrey and Sussex hospitals. Phase 1 was about delivering those things from our sites, from Ashford, Woking, St Peters sites, delivering a surgery at Ashford and physiotherapy back here again. Phase 2 is about how do we work with the Royal Surrey Hospital and Sash Hospital, that our consultants who have we taken on to do this work can actually do their outpatient clinics in their organisations, so that we're providing our services, the Elector Centre, closer to where those patients live. And how do we look at our capacity across the 3 organisations and balance out our waiting times? And when that changes, it's what we call dynamic distribution of capacity, that we can share out the capacity of these new theatres in different ways to ensure that all 3 organisations are benefiting equitably from reduction in waiting times. We're doing work at the moment around not just the outpatients, but also pre-assessment and physiotherapy, how we can provide those services locally. And we're also looking at ratifying the name of our centre that resonates across Surrey heartlands. What this is all bringing us to is, what is the compelling, exciting orthopaedic, the vision for orthopaedic surgery, how we deliver services across ourselves and our 2 partners in this endeavour. So we are bringing our clinical teams together. We now meet monthly, myself and my 2 chief operating officer colleagues at the 2 other hospitals meet with our chiefs of service, chiefs of anaesthesia, we call them divisional directors here. We all meet together to look at not only how we're using and planning to run the capacity in the current facility, but how do we include Ashford, and what role does Ashford play as part of our vision, our combined vision for orthopaedic surgery? And that really is quite exciting, doing something different. So this pulls together the things that we've heard through different sides, particularly here now, about collaboration with our partners in quite a different way. So I hope that's provided you with a little bit of information about something very exciting happening at Ashford. I think that's the end of my slides there. And I think I'm handing, I'm not, I've got one last slide. This shows the phases that we can have in terms of future. So the yellow box is where we currently are around delivering our services. We're trying to deliver what we said we was going to deliver in the business case, additional surgeries for patients. We're looking then to involve our neighbouring hospitals, which we're doing now. And as we move on through the evolution of that journey, we're looking at not just our partnerships and how we have the exciting clinical vision, but also what can we do? And as I described, it's about R&D. It would be some partnerships with research institutions. Could we be looking at where we are, industry standard setting levels of utilisation? We could also maybe in the future look at self-pay in other markets. So a really interesting vision and potential there for the next 5 years. And I think now I am handing back to the chair. Thank you, Caroline.
Thank you, James, and thank you, colleagues, for your presentations. I hope that's brought a bit about the Trust to life for guests. Thank you very much indeed. Okay, so now we're moving to questions. We've had a few questions sent to us in advance, so I'll do my best to paraphrase those and pass to the appropriate person. I won't read out the people's names who've sent them because I don't know if people would want me to do that, but make yourself known if you wish to. Okay, so we'll do that. And I also noticed there's a question been posed in the chat, which I will pass to Pammy because it's an HR question, so she can perhaps have a look at that while I'm talking. Okay, so first of all, this is going, Katie's going to answer this one. We've had a question about parking for members. Are members able to access free parking, Katie?
Thanks very much, Caroline. I always find that car parking questions get allocated to the Chief Executive to respond to. I think I'm afraid it's not going to be the answer that people might hope for. We clearly need to preserve our income and all the associated revenues for direct patient care, and we wouldn't be able to apply a blanket rule that members of the trust would be able to access free parking. There are obviously all kinds of concessions and support that people can access, patients can access attending our hospital for appointments if they're unable to afford to pay. For their parking, there's a number of routes either to seek reimbursement, refunds, or to access passes, particularly for certain types of patients or carers visiting patients, particularly longer stay patients. So there are clinical exceptions, and there are also ways to get refund for any travels to and from the hospital and parking for those in financial need to do so. But we certainly, I'm afraid, wouldn't be allocating free parking to members. Our own staff have to pay for parking, so. Thanks.
Thank you, Katie. Okay, second question. How do we address the mental health needs of patients as well as the physical needs of patients when they're in our care? And that one's for either Ellen or Mel, depending on who wishes to answer that. It's a clinical question.
Thank you, Caroline. I think we're both going to try and answer that question. So from the and thank you. I thought it was a good question actually to ask us. From the physical side of things, we like to try and keep people as independent or as close to their baseline daytime function as possible. So physically, for those who are mobile, we want to keep them as mobile as possible, but we ascertain falls risks assessments on them so that we can put things in place to make sure that they don't fall and injure themselves, but we don't want to stop people from walking. From people who are less mobile, we do assessments to protect their pressure areas and make adjustments where required. Nutritionally, obviously, because nutrition is extremely important, we take into account all their conditions, maybe diabetes or celiac, and anybody that's highlighted that might need additional help. We've got dietitians who come and make assessments and offer advice, and we keep a very close eye on what people are eating and drinking. We can offer assistance with meals if people are unwell and can't feed themselves. We ensure that they've got good mouth care and their dentures are fitting properly, and obviously the hearing side of things as well. But obviously trying all the time to try and keep people independent. And then obviously on top of that, the other physical side of things is to treat their underlying conditions and try not to keep them in hospital longer than is absolutely required, because what we don't want to do is let people decondition whilst they're in hospital, which is really important. So we work very, very hard to try and keep people in hospital for as short a length of time as possible. And I think Ellen's going to help answer that. How do we address the mental health needs whilst people are with us in our organisation? Thank you.
Thank you, Mel. Yes, so we have a range of practitioners who support patients as well, who address patients with mental health needs. We have learning disability specialist nursing team. We have got dementia nursing and OT team, who work together under our safeguarding team. And we've got a psychiatric liaison service who a medical team supported by a nursing team who review all of our psychiatric patients with and without a physical illness as well. And we work very cohesively together and have a daily MDT actually, which has been very beneficial to us. And we're just in the progress of appointing an enhanced care team, which will support us to make sure that we have a daily nursing review of patients with mental health issues in the trust as well. So thank you.
Thank you very much. Okay, next question. We've been talking about the diagnostic centre at Woking for some time, and I think we have one of our guests who would like to really know more about that, because we've been promising it will be open before now. So where are we, Tom? I think you might have covered this a little bit, but perhaps you can give us a bit of clarity. Thank you.
Sure. Yeah. Thank you. Yeah, I did mention this. So the diagnostic centre, part of it is already open, as I've said. So we opened the respiratory and cardiac testing facility, which is a new facility there, back in May. And then we've brought some other diagnostic services online as well. So we're currently able to offer X-ray, phlebotomy, audiology for adults and children, some dermatology diagnostics, DEXA scanning, bone density scanning, which we've had there as well, ultrasound. The question really, I think, is about the new build, and I think is partly inspired by the disruption that we've all suffered as a result of the building works there, which I have to say have been delayed. It hasn't been a straightforward build, and we don't own the building, which makes things more complex. But we are, as I say, taking delivery of the building components this weekend, and we're currently on track to be opening that new build and the related diagnostic facilities, which are the mammography, the CT, additional CT, and the MRI before Christmas. So hopefully that answers the question.
That does. Thank you very much indeed, Tom. Now we've got another question about car parks, although this is rather different. That we have somebody who would like to understand if there is assistance available for patients who arrive in a car park in their own car, but perhaps don't have the mobility to manage to get from car to their appointment with ease. How do we help people in those circumstances? I think that's going to Simon.
Yeah, thanks, Caroline. I think this was raised last year, and it's one that we've struggled to answer, in all honesty. It's not to do with the technology. It's relatively easy to call into a hospital or have an external unit in the car park to request assistance. But it's something we struggle with the staff to reliably kind of service. So at the moment, we're reliant on an alternative means. Obviously, we offer transport services and support and other arrangements that way. But we haven't been able to answer the individual specific question about how would we support someone in the car park requesting help. Now, obviously, they can call through to outpatients, and we would do that. We would do everything we could to support people. We do have wheelchairs and support available, but there's more to be done about trying to answer that reliably, Caroline, in all honesty.
Thank you very much. Well, I think it's something that we should consider as we're discussing an estate strategy, and which we are currently doing and in the process of putting together. So it's a very useful question to have in our minds. Thank you very much. Okay, sorry, my light's fading in my room, so forgive me if I take a little bit of time to work out what my own writing says. Oh yes, we've got a question as well about difficulties contacting the trust to rearrange or cancel appointments. It is taking some patients a huge amount of time to actually get through in order to do that. I think, James, you're taking this question.
Yes, I am. Thank you, Chair. Yeah, with the example that was raised is, I mean, no examples are acceptable. The example that was raised, we know that the department in particular has had a shortfall in staff in the last 48 hours. That isn't where we want to be. The complaint the question that we got, the experience that the patients have received trying to get into that service today has not been acceptable. I apologise for that. It is not what we strive to deliver, and it was not what any of us would want to be on the receiving end of. The second part of that was around an email address that was incorrectly put onto the MyCare pages of our website. We apologise for that. It has already been prioritised to be changed first thing tomorrow morning, along with a secondary check of every single email address on that page. So That's it, Caroline. Apologies for that. It is not where we want to be. We have a unique position in staffing in one of our departments in the last 48 hours, and that is a mistake on the website that we have. The correct email address is on our letters, but not on that piece of website. So, we're sorry about that, and it will be changed straight away.
Thank you. Well, very useful that it's been brought to our attention. And I think, it's certainly a question that's useful for board members to understand. It's something that we can ask about in board meetings now as well. And, access to our teams to arrange appointments is vital, of course. Jason, did you want to say something about that? You put your hand up.
Yeah, yes, please, Caroline. And just to say, of course, as I mentioned earlier on, our ambition actually is to empower the patient. So through our patient portal, in the future, we want to give that option to patients to reschedule appointments themselves. And of course, then that would see an end to these types of issues at some point in the future. Thank you.
Thank you very much indeed. Okay, very good. We're working our way through these questions, and then I'll move to people who are here and want to ask a question themselves. There's a question in the chat which I'll pass to Pammy, which is about international recruitment. Do we have a programme of international recruitment for staff? And if we do, how do we support those who have who experience visa restrictions and need additional help to navigate that?
Thank you, Chair. Absolutely. We've got a very, very clear international recruitment programme, and one of our key drivers is to support that talent and promotion to enable us to retain the best that we can. Our programme has been in place for many, many years, and we're always looking at people who can bring in that extra little bit experience and knowledge. And yes, so just to answer that core question, Esther, it's a really, really good question, and we're always minded to take that forward. But what I'd like to also add is that we now have a combination of program developing a local talent, which obviously means people are already here, either on a visa or otherwise, and then supporting them, navigating them through our program. Ellen's on the call, and I know that she's very, very supportive of the program, and I don't know if Ellen wants to add anything more than that. But if you want any more information, happy to take it offline. And I know Kate Colburn has also been supporting our recruitment, so can probably add a little bit more to our overarching program. So over to Kate.
Good evening,
Thank you.
everyone. Oh, good evening, everyone. Thanks, Pammy. Yeah, absolutely. We have been supporting international recruitment for IHPs as well, and we've recruited 6 occupational therapists and 15 radiographers internationally, which is brilliant. But I did have a question, actually, Pammy, in terms of, so for AHPs, we are still recruiting internationally if people are currently residing abroad, but I didn't know if nursing was still doing that or not. I'm not saying that we're kind of funding all of their flight costs and everything, but I was informed by nursing yesterday that they were only recruiting people that were already in the UK. Is that, I just wanted to clarify that. Is that correct? Or because we're not doing that, we are taking internationally.
Shall I answer that question? Sorry. Yeah. Okay.
Thank you. Thanks, Ellen.
Thank you. Yeah. So broadly, I'll answer that question in a moment, Kate. So broadly speaking, just to say, since 2020 we've had 491 internationally educated nurses, which we now call global majority nurses, enter into our trust, and have been supported through our clinical practice education team to achieve their OSCEs and a Nursing Midwifery Council PIN number. 70 of those were in the last year, which was the final year of national supported recruitment. And we've done very, very well on our recruitment for registered nurses. So we didn't need to do any more at that point in time. We are assessing the need for that currently for any future demand. Because we actually almost closed all of our registered nurse vacancies at the time, but we've got turnover. So we're not currently having a national recruitment, but if we need to fill fill any future vacancies, then we would have to consider it as an independent action, which has been done by many trusts before that was picked up nationally. But just also to say, we also recruited 7 midwives internationally, and then obviously, as you've said, Kate, a range of other roles.
Thank you. Thanks, Ellen. I think Esther, the lady who asked the question, would like you specifically to just discuss how you help people who are already in the UK, but perhaps need visas to work for us to navigate that. Is that something that we're able to support?
So visas, we can't support visas in their own right. We can support nurses who are in the country and not currently registered. We can get those onto a pathway to support them to become registered, but we can't independently support visas, so we can't do that.
But we can help people navigate the system.
That's useful. Help people to navigate the system.
Okay, thank you very much. Okay, so we're moving on to more questions now that have come in from in the chat. This one's going to go to Simon, I think, because it's about the implications of running an annual deficit and the knock-on effects, perhaps, on how we address deficits and if they have impacts on the services we're able to offer. Therefore, Simon.
Yeah, so I mean the impacts are ultimately serious in that, you know, we have to have the cash to back any deficit, which we're fortunate enough at the moment to have, but that won't last forever, Caroline. In terms of the NHS response, then increasingly organisations are going into some form of special measures that normally involves some sort of additional financial support to address their issues and bring themselves back into balance. But there's a lot of organisations across the NHS in that position. We're not quite there, but that's certainly a risk for us. So really, you cannot sustain a deficit for any length of time, I think, is the short answer. And as a result, we have to redouble our efforts to address it.
Thank you. Okay, that's good. Yeah, it's difficult, isn't it? Okay, one more question about delayed discharges. Does the trust work with local authorities, community care providers to help avoid delayed discharges? Who wants to take this? Is this Tom, maybe, or is it James?
It's me.
Okay.
So the answer is yes. But technically, we don't have local authorities anymore, but we have. We are doing a number of things. There are 2 big ones that we've got on at the moment. One is working with our adult social care partners, community colleagues, and our discharge team. We've setting up our transfer care hub, which is soft launch next week. And this is an exciting new way of it's discharge to assess. It's a way of patients being their needs being considered by an MDT altogether. So it's not referral to a particular organisation. The organisations meet 4 times a day as an MDT, assess the patient's needs and look to get something in to support those patients, support their needs as soon as possible. That's the first thing, and that's really quite innovative, quite exciting. The second thing is, at the moment, as we're heading towards winter, working with our partners, we are doing MDT ward rounds of the longest waiting patients as well, of particular pathways to care homes. That has happened, that is happening every day this week, actually, apart from Friday. And we're already seeing some of those patients that were seen yesterday really start to go home today. So two good pieces of work that we are working with adult social care and our partners. Still more things that we can do together, but that's 2 good examples of where we've been in the last 2 weeks. So.
Good. Thank you. I think the answer is a resounding yes, we do. And lots of different pathways. Thanks for the examples, James. Another question in the chat about patient transport. What are our plans for enhancing patient transport? Katie is waving, so I'm assuming she wants to take this.
Yes, well, you know, I don't I wish we weren't having to answer this question, but so the message is that the performance of our current patient transport provider is woefully inadequate, and it is causing all kinds of problems, both in terms of access to clinical services, for patient experience, for the day-to-day running of our services, both inpatient and outpatients, and it is driving a lot of additional unnecessary reactive costs where we're having to purchase non-emergency patient transport through other providers. So we are putting pressure at the highest levels. I'm managing this personally with very senior colleagues at the ICB. I've had another exchange of emails with them this evening following some further feedback from colleagues at Ashford Outpatients yesterday. So I think we have some tentative plans as a short-term measure to bolster the capacity we have with an alternative provider, but that goes nowhere near solving the problems that we actually have. So it's very much a message of unacceptable at the moment, incredibly frustrating, because we neither provide that services nor do we commission that service. So we're having to sort of act through an intermediary, but I am personally trying to negotiate a better position with this. And I'm sorry for all our patients who are impacted, as well as our staff.
Thank you. It's very much on my radar as well to talk about at board level. So one way or another, we will certainly keep raising this, Kate. Thank you very much for raising it tonight, because it's a really important matter. And if we can resolve it, we will solve quite a lot of knock-on problems. So thank you. Okay, in which case, I think all the questions that have been submitted in writing either prior to the meeting or on the chat have now been answered. And we have one member with her hand up, which is Gloria. Gloria, would you like to ask a question? You might need to take your microphone off mute, Gloria. Thank you.
Yeah, can you hear me? Yes?
Yeah, well done.
Yeah. Yes, I was just typing it because I saw that everybody else had typed. However, you've got me before I quite finished. What I wanted to ask was, what I've said here is, whilst using modern technology and giving the patient the opportunity to be in control of their own treatment, I'm concerned for those who are unable to use this facility. There'll be quite a number amongst the older people who are unable to do this, to use their telephone, log on and do all the other stuff. Can we be assured that there will be a safety net, let's call it, so that they do not fall through the system and are forgotten? Will there be a well, as much as we can get one-to-one now, will there be people following them up in the traditional way that most of them will enjoy and expect?
Thank you, Gloria. Yes, it's very important. There's lots of people who don't access digital methods of communication and aren't likely to start doing, and we completely understand that. Jason, do you want to answer this? How do we make sure that we provide equivalent access to our services for those who are digitally excluded?
So thank you, Caroline, and thank you, Gloria, for asking that question. So we call this area digital inclusion, and that's really important. So what we're not doing is withdrawing all of the services and the way we offer the services.
Okay.
Instead, what we're doing is now offering additional mechanisms of reaching out to us and, of course, being empowered. Now, in the future, though, there's going to be different forms of empowerment, including proxy access, whereby you can allow someone to transact on your behalf, like someone, for example, that may have a lasting power of attorney for health and well-being that could transact, or adults that transact on behalf of their children. So there's lots of other ways to do that. Also, in Northwest Surrey Alliance, we've been working with a charity who reach out and actually help educate citizens as such and help provide them technology as well. So there's different means and ways as such, but what we're not doing is actually withdrawing things at this point. We are just adding more and more in. Of course, at some point in the future, though, we'll have to take another look around what percentage of patients are interacting on what certain mechanisms and work out which ones make the most sense in a long-term phase.
Yeah.
But right now, we're just layering on more and more. So thank you.
Okay, thank you.
Thank you very much. I've got one more question come into the chat about the transport service for staff and patients between the two hospitals. Kieran's asking about the hopper, but actually we have a more sophisticated bus timetable now. Simon, do you want to just explain what that's about?
Yeah, so we've gone into partnership with White Bus, who provide, I think it's the 446 bus services, which now go all the way from Woking, via St Peters to Ashford and on to, well, Heathrow almost. That service is now doing really well. We've almost got record numbers of staff using those services, but also the public, and it's improving access to St Peter's site in the main. It does take longer to use that bus than the old hopper services, which could go direct and dodge traffic and weren't on fixed routes. But it's certainly a more sustainable, a greener, a better overall answer. But yeah, there are still timing challenges. We've worked really closely with the County Council and White Bus to improve the timetable and address staff's concerns and those sort of issues, Caroline. We'll carry on tweaking it, but it's a service that I think will go from strength to strength. I think overall it's to be welcomed.
Very good. Thank you very much. I have one more question from, I think it's from Stephen. Please go ahead, Stephen.
Thank you. The intensive development of the somewhat laughingly called St Peter's Quarter, I know has come right up to the boundary of the St Peter's footprint, which raises two things in my mind. One, presumably that does limit the opportunity to expand the site further. It may have been that was the limit anyway, and you couldn't have gone beyond that. I don't know. That's the old Botless site. And secondly, to what extent, I mean, there was reference earlier in the presentation about staff accommodation being improved. To what extent has that development included any provision for staff, either on affordable purchasing or affordable rental basis? Thank you.
Thank you, Stephen. Who wants to take this? I think obviously we've got two parts to the
probably me,
question.
Caroline.
Yeah, go ahead.
Okie doke. So the development of the west site was obviously for private accommodation, but as part of that arrangement, we've negotiated for Optivo, it's now called Southern Housing, to expand their accommodation on our site. So it was a joint deal, that essentially, Stephen. We've substantially increased the numbers of units on site. It's something like 400 in total that are available. They're of a much higher quality than they ever were. They've got all the mod cons, everything from solar panels to car chargers, everything else that you might want in the long term in future. So we've got an arrangement that's provided the best of everything, I think, on site. In terms of development land, we have two options. Obviously, we have a large central area in front of A&E where the car parks are that we could potentially develop. And also the main buildings can have one more floor added, theoretically. So across outpatients and some of those other areas. That wouldn't be a cheap option because there's a lot of mechanical engineering and other kit on those roofs, but we have a variety of options despite having less land now than we had in the past. So I don't think we're curtailed in any way, really.
Thank you very much. Okay. I think we are approaching the natural end of the meeting. I think we've answered everybody's questions now. Thank you very much to everybody for joining, to all the members particularly, because that's why we do this. It's very important that we hear from you and that you hear from us. I hope we have answered your questions adequately. Thank you particularly for all staff members, all the executive team who've given excellent accounts of what we do in the organisation. Of course, to Michael, our lead governor, and other governors for their contributions in general to the trust, but also for joining this evening. I think that brings us to a close. Thank you very much indeed, everyone. I hope you have a lovely rest of evening and a lovely rest of week. Okay. Thank you and good night.
Thanks, everyone. Bye-bye.
Thank you.
Thank you.
Thank
Thanks.
you.
Bye.
Night. Goodbye.
Thank you. Good night.
Thank you.
Thank you.